Okay, good afternoon. Thank you so much for joining us. My name is Jenny Baumgartner, and I will be the moderator for this session. So, on behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome you all to the Prevention in Focus webinar series. So, our webinars feature talks from prevention experts and thought leaders who are making advances in public health. The Prevention in Focus webinar series provides an opportunity for the broader scientific community and members of the public to learn about the latest prevention research findings directly from expert voices around the world. So today we're absolutely thrilled to have Dr. Heidi Blanck from the Centers of Disease Control and Prevention, and she will be presenting spreading effective interventions to support healthy child growth, CDC's data modernization implementation science efforts. Ms. Brahma Ramba Akautha, she's a health scientist at the Office of Disease Prevention. She will provide an introduction of Dr. Blanck shortly. I'll say before we start the presentation, I'd like to go over just a few logistics of today's webinar. All lines will be muted upon entry and will stay muted throughout the presentation. There will be a question and answer session at the end of the presentation, so please submit your questions for Dr. Blanck to the Q&A pod directed to all panelists. You may open the Q&A pod by clicking the arrow to the left of Q&As I've displayed here on the screen. We will monitor these throughout the session. So please note that the webinar will be recorded and posted at a later time to our website. So I know everyone is very excited for this presentation, so I'll now go over and pass the mic to Brahma Ramba to introduce today's speaker. Take it away, Brahma.
Thank you, Jenny. So Dr. Heidi Blanck serves as a branch chief for the CDC's Obesity Prevention and Control branch in the Division of Nutrition, Physical Activity, and Obesity. Dr. Blanck has more than 23 years of public health experience at the CDC and has authored over 150 papers and reports in the areas of nutrition, physical activity, obesity, and environmental exposures. She supports teams working on national and state surveillance, applied research guidelines, and technical assistance to support health and health equity through early child care and education environments, healthy food service, clinical and community pediatric interventions to support child growth, and health and community efforts to support food and nutrition security. In addition, she supports agency research practitioner partnerships related to nutrition and obesity policy research and evaluation network, commonly known as NOPRIN, the National Collaborative on Childhood Obesity Research, you may know this as NCORE, and also serves as a liaison to the National Academy's Roundtable on Obesity Solutions. Dr. Blanck received her PhD in nutrition and health science from Emory University and a master's in molecular biology from the University of Michigan. And she's also an adjunct professor in Emory University's Nutrition and Health Science graduate program. We are really lucky to have Dr. Blanck today. Over to you, Dr. Blanck.
Thank you, Brahma. Thank you to the NIH for inviting me here today. Next slide. I'm really excited to share with you today some of the work that our division has been doing to really spread and scale interventions going from the research trials out into public health practice, and also how we try to incorporate data, technology, and modernization as part of this. Next slide. Next slide. So our division approaches supporting an individual's nutrition, physical activity, and healthy lifestyle across the lifespan. We have work that supports breastfeeding and early maternal nutrition. We have work in the 0 to 2 space around early child nutrition. And then much of what I'm going to focus on today is in the age group of work that we do in the early care and education, or what we call childcare, some of the school and youth programming, and some of the work that we do for children who already have obesity. But I did want to share that on the right-hand side of the slide, we also have programs that are in the communities around things like food service. So that's nutrition standards within a number of places. We also work in nutrition standards in the charitable food system, and a lot of work that we do in Active People, Healthy Nation, and really trying to have better built environment so folks have access to physical activity. Next slide. So today, as we talk about healthy child growth, we think about obesity and the impact it's having on our children. So as many of you know, child obesity tracks into adult obesity, but child obesity itself can have many impacts, including bullying, stigma, and a lower self-reported quality of life. It can increase high blood pressure, high cholesterol, and issues around early diabetes. As I show here, there are a number of adult conditions, including 13 types of cancer that have been causally related to obesity. And we know that childhood obesity is relatively inexpensive to prevent and treat. And so we really want to think about both prevention and treatment in these early ages. Next slide. This is some of the latest data from the National Center for Health Statistics using the National Health and Nutrition Examination Survey. So this is looking at really the last 20 years. This is the data we had before the pandemic. The graph represents our 2 to 5-year-old children in the bottom line, 6 to 11 in the green, and our older teens in the 12 to 19. And as you can see, unfortunately, many children are entering kindergarten already having obesity, and about 1 in 5 or 1 in 4 having obesity already as they're going through the school years. Next slide. We also know we have differences or disparities in child obesity prevalence. These are from a number of different federal sources, but this is just an example of some of the disparities that we see. We see this by race, ethnicity, by metropolitan status, by household income. And so we do want to be thinking about social drivers as we think about the data that we're seeing. Next slide. So as we think about how we can support healthy child growth, we really think about what are the conditions for healthy growth in the public settings where we really can intervene from a public health perspective. So we think about how do we take trials that maybe the NIH funded at the level of a type 1 efficacy or effectiveness, and really think how do we adapt those out into the field in a number of settings, rural, frontier, small town, urban environments. How do we take that good research? And we're thinking about this because we're really trying to think about children holistically, right? We're trying to think about their quality education, and we're trying to think about where do they spend their days. So they spend their days in the school, might be in park and rec after school, and then they have some access to healthcare. So we think about this because when we meet with business leaders and others, although they care about obesity, they also care about things like job performance and having a good workforce. So we think about things like school readiness, social skills, and the opportunities for higher academic achievement. And as part of this, we also then really want to think about what leads to lifelong behaviors, right? We want folks to enjoy physical activity. We want people to have good relationships with food, positive body image, good self-esteem, and stress reduction skills. So in many of the programs that we're thinking about, we really holistically try to think about the whole child and the whole family. Next slide. This is a pipeline that was developed by Sandy Noom, Tina Smith, and Jenny Core at the CDC. And it just tries to put into context kind of the different approaches that we see in research. And it's quite busy, but what the CDC often tries to think about is what is the evidence-based interventions that we've seen in the literature through randomized controlled trials or others, and what do we know about what it takes to get them out into the field? So this diagram just shows a little bit about areas like outreach, engagement, dissemination, adaptability. We really have to think about how do we get more of the interventions into more places to impact more children. Next slide. So one of those places we think about is childcare. If I was giving this talk on a panel with my colleagues from USDA, we might have been thinking about the WIC clinic. But in the division I work in, we have a lot of work that's really supporting the 0 to 5 through the early care and education. We think about this because this really can directly influence what children eat, but it also can build a foundation over their lifetime. Next slide. So we know also that quality childcare, especially in the United States, has some really good outcomes related to long-term. So we know, for example, that children who participate in Head Start had significantly healthier body mass index by kindergarten entry. And some of the papers we have that have looked at children over decades actually show long-term outcomes, including lower substance abuse, lower BMI, decreased CVD risk, better educational and attainment, less crime, more employment, and better income. So we really look at the quality childcare as a high return on investment, and really thinking about early education then as a critical social driver or determinant of health. Next slide. So what do we try to do? Well, we try to actually embed obesity prevention then into the systems and standards that are part of the early care and education or child care system in the United States. So although we have national caring for our children standards, which really set the stage for safety and health, States actually implement their own sets of systems. So each state has its own licensing, has its own quality rating. So we really work with our state partners to embed these to create foundational policy. But then within states, we have local communities and actual facilities. That's when we can really tap into the evidence-based interventions that have been developed for the actual facilities. And then we have to think about the workforce. Who are the folks implementing these interventions? We know that this is a low-paid, low generational wealth set of providers, but these providers really care about children. Many of them have chose this profession because they really care about child health. And so we've got this great opportunity to really improve professional development around obesity prevention with really ensuring efficacy to implement the best practices. And our division does this through mostly state and local recipients through what we call cooperative agreements. Next slide. So currently, our division funds 3-level state-level cooperative agreements, and we're able to reach 33 of the states and the District of Columbia. And then we have 2 local-level granting programs, one called REACH and one called the High Obesity Program. And these support 23 local jurisdictions. So currently, we're able to cover about 3/4 of the children in the nation under 5. And we really are aiming for sustainable change. Next slide. So this is an example. I mentioned state policy. So we work with states for them to look at their licensing and to see what could they improve around breastfeeding supports, nutrition, physical activity, screen time reduction. And the bottom here shows, as we've been monitoring the annual licensing changes, which were part of a Healthy People 2020 objective, we've actually seen 39 states update their licensing standards to include more of these key pillars. So you can see where we were in 2010, with the nation, we had pretty poor uptake at that time of the obesity standards. And this great diagram on the right here of the 2018 map, seeing so many states making improvements. Next slide. So in addition to that level of policy, state policy, we also see facility level policy change. So folks may have heard of NAPSAC, the Nutrition and Physical Activity Self-Assessment for Childcare. This was NIH funded as well as CDC funded, and they also at this point are looking at their adaptability trials. Harvard's Choices program did a cost effectiveness review and found that among the interventions focused on children less than 5, that in the US, NAPSAC actually showed the strongest evidence for early impact on child obesity risk. And what's really exciting about this, it went from these really, randomized type trials out to spread and scale. We now have 22 states using a version of NAPSAC called Go NAPSAC, which is an online portal that really allows states to purchase a license to support their local child cares. And many of them are funded through DNPAO program, but some of them receive SNAP Ed funding through the USDA. So this is just a great example of how state systems can really support facility level change by embedding. So we've seen folks embed this Go NAPSAC into their quality rating improvement systems, or QRIS, their technical assistance networks, and recognition programs. So this really is a national success to see where it was funded from NIH and now how we continue to support it out in the field. Next slide. Here's an example here then showing again that when this was developed, and you may have heard that it often takes about 17 years for something to go from a research trial out to practice. Well, this is an example of where we are now. We're 20 years out, and this is a great example. But this is why implementation science is so important, right? Is for us to catch those early wins, understand those best practices, what's acceptable, how much penetration do we have, what is the cost, how do you maintain these things? So this is really exciting in the work of Diane Ward, the UNC Chapel Hill, and many of her co-authors, and really understanding how do we take this research trial and move it forward. And as you can see here, as of August of 21, over almost 6,300 programs across the nation are using this, with over 307,000 children. Next slide. I want to switch gears a little bit from the prevention work that we do in childcare over to some of the work we do in healthcare. So you may be aware that in 2007, the American Academy of Pediatrics put out its expert committee recommendations. So it's been quite a long time since that group had put out new guidelines. Well, we're very excited, as many may know, in mid or early October, the AAP is going to release new clinical practice guidelines around obesity in children. Meanwhile, while we're waiting for that at the level of the healthcare sector, we already have a 2017 U.S. Preventive Services Task Force report with a grade B recommendation for child obesity, showing that children 6 and over should be screened for obesity and offered or referred family healthy weight programs or intensive behavioral modification. Next slide. So here, for example, shows that what the Family Healthy Weight Program is 26 hours of counseling over 2 to 12 months on nutrition, physical activity, and behavior change. And the good news was that the AHRQ review showed over 60 randomized control trials showing that these can promote health and result in 5 to 20% reduction in excess weight. What's really exciting is many of these programs show some spillover effect in that other family members, such as the adults and caregivers, also lose some modest weight, and that we don't see detriments to child self-esteem. We actually see improved quality of life, improved self-esteem. And so, we're always monitoring among children around healthy nutrition and physical activity. And so that's one of the things I want to point out as well, is that although the family and the parents may enter the discussion with a physician about being referred to these programs because of a child's weight, they really focus on enjoyment of physical activity and how to use nutrition facts labels and other things to help support the family in a nutrition change. So we really want to ensure that we're not stigmatizing, we're not leading to any kind of concerns around eating disorders. Next slide. So this has become even more urgent. So the CDC, many of us have been involved in the COVID-19 pandemic. And this is some of the work. A couple of these are out of my group. So we found that among youth with COVID-19, those with underlying medical conditions, including excess weight, had an increase in likelihood for hospitalization and revert in severe COVID-19 illness. We actually analyzed this data in large electronic health record data. The next one also among youth, we showed that the average rate of BMI increased double during the pandemic among children. This is mostly among children who already had high BMI, overweight or obesity at pre-pandemic times, and children 6 to 11. We used a new software algorithm that we've helped create called Growth Cleaner. And this allowed us to use timely electronic health record data to look at what was happening to child growth during the pandemic. And then just 2 more points that unfortunately we are seeing an increase in incident diabetes among those youth who had COVID-19, and there was an increase in emergency room visits for eating disorder conditions by youth. So this just increases the urgency for why we need to be thinking about children holistically. Next slide. So when we look at our work that we're supporting in the pediatric area, it really is this care continuum that we want to think about prevention of obesity for all children, what we'd call universal, and then treatment options for kids with excess weight, or what we call high risk. So on the left, for example, here, it includes screening all children. This is using the growth charts for looking at optimal weight, using screeners like the 5210 to look at health behaviors around things like sleep and sugary beverage intake, and also ensuring that social drivers such as food insecurity, housing, transportation are assessed for the family, and really referring and ensuring that they have social assets. On the right-hand side, I'm going to talk a little bit more about this work, but the work we've been doing is to support the new clinical practice guidelines, what we call the Family Healthy Weight programs, and then work that we've been doing also to support the conditions across the US to ensure that team-based care in that healthcare setting or out in the community can actually be billing and paying for these programs. Next slide. So as I mentioned here, the Family Healthy Weight Program, if you've worked in adult obesity, you've probably heard of the Diabetes Prevention Program, or the DPP. Components of an effective Family Healthy Weight Program are very similar in that this is really behavioral management, right? It's really supporting the child and the family through a self-management program. So these can be really helpful depending on where they're offered. So on the left here, just to show some of the content, and again, that they are very family-centered. And then the dose and delivery here, that they can be in the clinical or the community setting. So we have places like schools and park and rec, federally qualified health centers. These can be group and individual sessions, which often helps with peer-to-peer sharing. And then we have the option now with telehealth. We saw a lot of that during the pandemic, where programs pivoted to really meet the needs during the pandemic. Next slide. So the Family Healthy Weight programs, for example, here we see improved child and family wellness, less family stress, and more coping options. We see mental and behavioral health improve. Some of the metabolic markers have been shown. We published a paper with Denver on theirs, looking at blood pressure. We definitely have looked at a few of the studies that have shown reductions in diabetes. Happily, we are continuing to see cost effectiveness and cost savings data. Next slide. So what we have in the Division of Nutrition, Physical Activity, and Obesity is what we call CORD, or the Child Obesity Research Demonstration. We've been working with existing programs that have randomized controlled trials to work with them to create user-friendly material. Our goal is really to get this out of what we'd call the parent site or the university setting and really get into places and venues that serve low-income families. So this funding has been through CHIP, or the Child Health Insurance Program, as well as some of the work with Medicaid. So we've been really working using an implementation science lens to figure out what are the best ways so that other venues can uptake these type of programs. So for us, again, this is implementation materials, training curriculum, technical assistance, and quality control. And we're really trying to balance out this supply and demand issue, right? We have many families that are interested in this, but we lack the awareness among providers, among communities on what it takes to have them and how to make this community clinical linkage work with the referral process. Next slide. So this is an example. Just hit stop video here. You can still hear me. So this is an example showing the work that we've been doing across the nation. These are research demonstrations, but we've been lucky to have 3 versions of this, CORD 1, 2, and 3. We also have a program, COMMIT, which is our child obesity management through MEND implementation teams that we work with federally qualified health centers. And then some work that I'm going to talk about, which we call CODI, our clinical community data initiative. But this just shows the partners that we have across the nation that we've been working with to support this family healthy weight program and some of our data modernization. Next slide. So more of this can be read about in Childhood Obesity Supplement that we published last year. The primer, for example, here was written by Commander Ellie Goodman and our team back in our branch. And this one was titled Moving Pediatric Healthy Weight Interventions to Real-World Settings Using Implementation Science to Address Access, Flexibility, and Sustainability. So I invite folks to take a look at that supplement. Each of our sites has papers really talking about how they've gone about using implementation science. And I'm going to touch upon that a little bit. Next slide. So these are some examples of evidence-based family healthy weight programs. So I'll start with the top one here. So again, these have had decades of research funding, whether that's through NIH, the PCORI grants, or CDC. So Healthy Weight in Your Child is an intervention that is in the community setting. This is actually MEND, or the Mind, Exercise, Nutrition, Do It program that was licensed by the YMCA of the USA. And so we have YMCAs offering this across the nation, and many of them are receiving reimbursement through their state Medicaid. Yale has the Bright Bodies program, which has been in both the community and clinical setting and has published a number of randomized controlled trials. Our partners in Massachusetts have a clinic setting-based program they call the Healthy Weight Clinic. And we've been working with them to transfer some of their knowledge from Massachusetts to Mississippi in a project in CORD 3. And then work that's happened in Missouri on family-based behavioral therapy called RISE. And again, this one is based in the clinic setting, really uses a team-based care model to support families. And the exciting thing about Missouri is that they were able to bundle their diabetes prevention program for adults and this family-based therapy for children into a state waiver, which allows them to have a billable program to spread across their state. Next slide. And so as we looked at this, we really wanted to use REAIM as well as CFR and some of the other tools that have been used in implementation science to understand how could we develop really pragmatic measures in such a way and report these out so that the field really grows. We find a lot of times that the barriers and facilitators that are happening just are often shared, but they're shared in peer processing and through anecdotes. And so really being able to use these frameworks to publish manuscripts in a way that this whole field, the science community, can benefit. And we feel like this is really, really helpful, and especially that we want to collect data that is meaningful and acceptable to the families as well as to the implementers. Next slide. And another big part of this is promoting equity. So for individuals like myself who've had one type of training and approach, we really are moving into a time where we're really trying to ensure that we co-design our interventions with acceptability and meaningfulness up front. And so I would just invite folks to take a look at this Shelton diagram outside of the time here to really think about, what are the ways that we really can ensure that if we're going to translate these interventions, that we're really meeting the needs of the folks who are asking to deliver those. Next slide. So to get pragmatic about it, just to show you some examples. I'd like to thank Renee Porter and others for these slides. So these are some of the aspects that we've thought about from an implementation science perspective. So on our left-hand side, we can see some of these larger constructs. So acceptability. So looking at the provider. So for example, this might be the medical director at a federally qualified health center. It might be a nurse based in an after-school program. This might be health coaches that are part of the YMCA. We're really trying to understand of a person's workflow. How do we bring in these interventions in a way that really meets kind of how their day would go about, and what kind of satisfaction do they have from delivering that intervention? When we think about the then flexibility and adaptability in the middle there, really understanding from those individuals how they're able to design these things with vulnerable populations, for example. How do they think about time constraints? What happens when morale is low? So for example, if we have cohorts where we don't have the family members, maybe if there's attrition and maybe they're not attending. Looking at things like adoption, again, some of that data at the public health perspective is much higher up when we're looking at how many organizations are implementing intervention. But we need to be accountable, especially as folks who are really trying to spread and scale this across the U.S. to make sure that we're having uptake of these things. Appropriateness, really important for us, the fit of the program. For some places, a clinical setting may not have a large enough space for, say, the physical activity program that might need to happen. And then there are other needs around children, especially children who already have obesity. Feeling good about taking part in sports teams can be difficult. So sometimes really stepping into how does that program deliver kind of that safe and real motivating physical activity? What are the types of intervention variety that may need to keep the participants coming back? So just some examples here then of these constructs and how we go about thinking about how to apply those as we spread and scale. Next slide. And there's just a little bit more, if you're familiar with implementation science around issues like fidelity. So we're looking at aspects around web formatting, coaching, curriculum, how much training does team members have, and when do you need to kind of retrain? Again, if you're working in something like a clinic setting, you can think about your population catchment. You can look at your electronic health records to see children who maybe are part of your practice and who have high obesity, but really understanding how are you getting to the individuals who could benefit from that. So just some examples here. And then sustainability, really important with that to be designed up front for any program, really understanding, do you have a path forward? If the grant funding ends, what are your opportunities to keep that going? How does it fit in with the other systems of support? Whether that's a childcare setting or in healthcare, how does this become part of your ongoing offerings? Next slide. So this is just an example then of the work we've been doing in the federally qualified health centers with our partners at the National Association of Community Health Centers. So we worked with the primary care associations to really then get into FQHCs. So this has been a proof of concept with us, but we're very excited that we've been able to be in a number of states now, over 6 states. As we've been spreading the MEND program, and now really thinking about systems change broadly, really working on both the universal prevention areas as well as this higher risk area. Next slide. So one of the things when we work with the researchers is really thinking about, so we've had a randomized control trial. It moves through some levels of effectiveness, maybe to a couple other sites or a couple more years. But now when we've wanted to spread to other places, so for example, we're moving into other communities, rural communities, where maybe this hasn't been tried, moving to a telehealth model, moving to some place that, for example, maybe has community health workers that are certified and billable. Really trying to work with researchers with this implementation science hat to say, what is it that, that we really need to happen to keep some level of fidelity and integrity of the program, but where is it okay to make changes, right? So thinking about, what do we want them to do? So really trying to think through if we add new activities, are we losing any part of the integrity? Are we losing anything if we don't measure certain outcomes? So really trying to approach it with a real, flexible but rigorous research model, how we really think about integrity. Next slide. I want to talk a little bit more about data modernization. So we do capture data throughout the research demonstrations that I just talked about, but often in the pre-planning part of the decisions made by a local community on whether they should offer a family healthy weight program, they often don't know about the burden of obesity in their area. So, at CDC, we have things like the NHANES, which gives us national data. We put out data on 2 to 4-year-old obesity through the WIC program with the USDA. We have some data from the Youth Risk Behavioral Survey on adolescents, but we may not have data on the 6 to 12-year-olds, which are kind of the prime age group for the Family Healthy Weight Program. So we've been developing some proof of concept projects, and this is called CODI. This is our Clinical and Community Data Initiative. And we've done this work in both Denver, Colorado, and the Raleigh-Durham RTP area of North Carolina. So I'm going to talk a little bit about that. Next slide. So what we realized is when we holistically think about a child and we think about their days, we know that they're coming to the clinic and getting screened for obesity, but they might be going to school or childcare programming during the day. If that family is struggling with food security, it might be going to a food bank on the weekend. A girl might be doing Girls on the Run on Thursday nights. And so what's interesting from a research perspective is really understanding the actual dose that a child may be receiving in their community of obesity supports. And so what we aim to do was actually think about children as both space and time using technology, and really support those local researchers to understand if the programs they were offering was making a difference. So this is really an opportunity where we're leveraging information from clinical and community data systems to create timely and useful de-identified individual linked longitudinal data. So helping the researchers link children across time and space in their community and to do things like comparative effectiveness and other data. Next slide. So this is just an example then of when we've approached this with our partners, we've said, who has the type of information that's supporting child obesity? And you can imagine that in any community, there might be social service agencies and they're capturing data on an Excel sheet, and you might be in a clinical system and they have Cerner and Epic EHRs, and then you might be in another part of another school and it's using REDCap. And so thinking about the different types of data sources, the different ways data might be collected, and how each of them is a little bit siloed, and it really doesn't allow us to understand the full effect of our interventions. So this is what CODI tries to do, is really think about the data assets that exist in a community and how could we link them together. Next slide. So this is what we've been thinking about as a framework then. So we work with our partners at the local level in North Carolina and Colorado. And so we have groups like academics, public health, social services, and health services. We really want them to standardize their data. And so we think about what are the types of technology models that exist and how could we apply that. So both the community partner data, our social assets, and clinical data. Really wanted to preserve privacy, right? And so we want the children, although we want to have researchers be able to link their data, it needs to really be de-identified in such a way to really protect privacy. And so we're actually using some privacy preserving linkage or PPRL technology that folks tell me is what they call fintech or finance tech. It's what banks use to actually chop up our data such that our information can flow across electronic systems without being able to be identified. And for us, this was really important. And then, our Growth Cleaner app, which is what we do for data cleaning, really allows us then to clean the data and make sure it's good quality. And we can actually then create this longitudinal record for a child. Next slide. So as I mentioned, these are still proof of concepts. We started a few years ago in Denver, which really has this great opportunity with a very strong children's hospital, the Kaiser Permanente in the area, and some of the social groups, including Hunger Free Colorado and Girls on the Run, and Denver Health, which is a unique system in that it has both public health and healthcare under one kind of entity. And so this is really where we started. Next slide. And then North Carolina has been our second pilot. This has included a number of partners here. Again, we, for the first time, included WIC as part of that data, but again, Girls on the Run, the park and recreation groups, and a lot of the health centers and the YMCA. So just really exciting to bring partners together who all care about child health and child programming, and really having them understand how their data could really support a bigger mission. Next slide. So here's just a picture of that, what we call PPRL, or privacy preserving record linkage, and just showing again that it really allows a person's data to be hashed and really de-identified, so that researchers can have information without personal identifiable information, or PII. And it also allows what we're going to look at is kind of a cloud-based query where none of the individuals are actually giving up their data. Next slide. So here's what we call a clinical community distributed data network. So again, my staff that work on this just kind of shows the data flow that we do a lot of this upfront work to get all that data quality and the data behind those firewalls in such a format that it's really structured for data capture. But then the individual researcher can query the local entities to see if that's the type of data that they are interested in giving. And it often comes to them in aggregate. And so, again, these are proof of concepts, but we're super excited that the researchers in these two sites have this ability with these linked data sets to answer questions that before this we really couldn't try. Next slide. So, so what is CODI, right? So this is really public goods or public technology. So a sustainable data infrastructure that leverages current electronic information in a community. But it's not a data reporting project. So at the moment, CDC is not, for example, putting out an obesity prevalence from one of these areas. It does allow data exchange with de-identified longitudinal data. So again, not going through medical charts, but really utilizing what's already there. And really this opportunity to collaborate with local and national experts. We have folks working on hunger, on housing, on even aging services. So again, really having so much of what's happening in a community, really thinking forward on how would we use this data as we see healthcare transformation and people wanting to see that prevention work in the community potentially is leading to less costly healthcare and less ER emergency room use, for example. This CODI model really would allow communities to see if it's making a difference. Next slide. So we're hopeful that those two projects so far, right, that it'll allow the clinics greater awareness of the community-based programs. So if they are screening and referring patients, that they really feel good about making those referrals and that the programs are supporting their patients, that the community partners really could see this data on health improvements associated with their interventions. For researchers, this really allows us to answer a lot of pragmatic questions around dose, maintenance, booster needs, allows to stratify information in a way to see whether zip code matters, whether there's a different effect if children go to one program over another. And we're hopeful, right, that decision makers and policymakers will see that there's a greater understanding of the chronic disease prevalence in a community, but also that programs that they might be investing in are mattering. Next slide. So I'll end there. Hopefully that just gives a little bit of information about the work that we're doing to support children across the nation through both our early care and education area, as well as our healthcare programs. But I'm definitely open for more questions about these and the other components of our work at CDC. Thank you.
Thank you, Dr. Blanck, for your wonderful presentation. That was incredibly comprehensive and a great overview of all the work you're doing at CDC. So we'll now move on to the Q&A portion of our session. If you can advance the slide, or maybe I can. Okay, great. So as a reminder, please submit your questions into the Q&A pod directed to all panelists, and I will direct those to Dr. Blanck. It looks like we did have a quick one that popped into our Q&A pod earlier, and this person just wants clarification. So for the family healthy weight programs that you mentioned, do you mean that they're offered at schools or through schools?
Great, thank you. So some of the programs that are offered in the community setting could be offered at schools. We have heard of some through the MEND program, the Mind, Exercise, Nutrition, Do It, which is part of the Healthy Weight Partnership. They actually offered these programs at night and on the weekends for families to take part in. So that made the school is such an anchor in a lot of communities. So yes, they could be offered as part of the school campus, but that it would be extra programming that a school and PTA could consider.
Great. I'll go ahead and ask you one of our questions as people start thinking about how to ask their questions for you. So many in the audience might be curious about the handoff of evidence. So you said earlier in your presentation that some of your evidence-based interventions come from those funded by NIH and others. Could you tell us more about this handoff process involved? How much evidence is really enough from NIH-funded interventions to reach this handoff process? And how do you, as you said earlier, catch those early wins? Could you tell us more about this?
Sure. I think that we look at evidence from a few different sources. So one would be the community guide. So really looking at both the reviews that are done that come out of the US government as part of community guides. So in the physical activity space, in the worksite space, in schools, we do have obesity related interventions that we often feel comfortable because the evidence reviews are so rigorous that we often look to those to see what has sufficient evidence. So that may be a process where really those systematic reviews lead us to a larger umbrella category, and then we may look at the individual interventions. Like others, we may be looking at Cochrane reviews and other types of systematic reviews. In the healthcare area, the U.S. Preventive Services Task Force reports and their guidelines are very important to us. But I will say there are then, another category then is the promising intervention. So sometimes you do see some patterns start to emerge at a local level where it might have a basis of a intervention program that may be started through NIH or some other funding. But then over time, the adaptability is very high. That's often when we really try to suggest, for some rigorous evaluation to come in to be able to show, right, that it is making a difference. But I will say that it's very helpful when folks use common measures, right, in the study outcomes, because I really do feel like that helps us, especially as folks do systematic reviews, to make sure that we're able to, find sufficient evidence. We do have to do some work in deconstruction, I will say, right? Some places want to implement interventions that maybe haven't been shown to be as impactful. And so it does take some retraining at times to come in and really support folks with new uptake.
Great. Thank you for that. We had a really good question come into the chat. So what are next steps for implementing CODI? Are there any roadblocks you've encountered, or maybe even any anticipated roadblocks in your hindsight?
Well, definitely COVID happened, during some of this, which kind of slowed down partners being able to have a lot of their in-person type meetings to really share, build rapport and trust. But we're next steps right now. We're working with the Public Health Informatics Institute, PHII, and building a CODI toolkit that will be available to the public. This will allow other interventions, whether that's pediatric asthma, or anyone else working in spaces that might be different than obesity, to look at the tools around data sharing and governance, to look at mapping to these tables of data that maybe are part of the EHRs. So we're really hopeful that toolkit will allow others. I think the biggest issue is for the startup was definitely time, right? It takes a lot of time to bring partners around the table. So definitely if a person is developing a grant application, really making sure there's enough lead time in the pre-implementation part of these type of projects.
Thank you. A question about obesity training and doses involved. So, how do you measure dose of obesity training? This person would think that a lot of the factors that go into that are not measured or recorded in a standard way in a typical EMR. Could you speak to that?
Sure. So for example, in one of our research demonstrations, we actually used, we used iPads to look at curriculum delivery. So for example, our community health workers who were trained on delivering part of an intervention, used some different formats to actually go in as it related to both, the curriculum they were taking in, as well as like when they were working with parents to understand, how many people were attending which sessions. So there's different ways, Catch, which is a very common school-based intervention, has some nice papers out on how it's really tried to capture, training of the curriculum, really looking at the implementers of these interventions, and what does it take for them to be high level, impactful, coaches or implementers. So I'd suggest looking at maybe some of the Catch literature, because you're right, it does take an extra step for the program, because you're not going to see that captured in something like the EHR.
Thank you. So I want to get to this question because I'm sure a lot of people in the audience are probably thinking it. So you have North Carolina, you have Colorado participating in Cody. So how can other states participate in CDC's Cody?
Great. Well, so Cody itself is a very large, complex system. But I think that there's great opportunities right now with a couple of the smaller parts of it. One is our Growth Cleaner application. So Growth Cleaner is available on GitHub as a software algorithm, as a public good. And so we've been actually offering at a number of conferences, workshops for individuals to actually look at their electronic health record data and to use that, to clean that. It can be used cross-sectionally, it can be used longitudinally. We start with the longitudinal to be able to clean data. So often in EHRs, and I found this myself, a practitioner may enter pounds when really it was kilograms, or they may enter inches instead of centimeters. And so there are some places where you can see all of a sudden a child's trajectory in that EHR goes in a bizarre way. And so Growth Cleaner looks for these common flags. It doesn't take out the data. It allows the researcher to really have control. And so that's an example where we're pairing academics and health systems. We're working with pediatric researchers, and they find many different uses, right? Some of it is looking at the burden in their health system to understand, do they have a demand that could lead to why they want to do quality improvement or offer a family healthy weight program. You can actually create almost prevalence estimates based on some information. So it is a healthcare seeking population within the EHR. So you do have to have that caveat. That bias is, I guess, called informed presence bias. But there are ways post hoc to actually do some weighting and raking to really account for the healthcare seeking population versus the general. And we've been working with NORC on some of that. And so we're hopeful that local folks will be able to use their EHR data to really create point estimates. And so that can really help inform and prioritize, the burden of obesity in their area.
Thank you. Another question that came into chat is this. Are there some ways the programs you've mentioned could be implemented by school-based health centers? If so, how does that process work?
Sure. So actually our sister division in the Division of Population Health, which oversees our school health branch, has a cooperative agreement with a number of school-based partners. That includes the School Nurses Association in the United States. And so often the school nurses are ones who may or may not be thinking about offering other opportunities outside of the school day for the health of the community. And so folks can get in touch with us actually around our family healthy weight programs. The other one is and I can provide this later, but the Healthy Weight Partnership which is the MEND program that we work with, is available. And on their website, schools and families and Park and Rec and others can actually approach them to see what it would take to actually offer those programs. So the nice thing about a school campus is that, if you're able to work with janitorial services and others, about leaving the building available for community members after hours, it allows then for siblings to come along, potentially be offered childcare. We know we've got a lot of working families that need accommodations. It also has a great space for physical activity. So that's one of the things that often there is a physical activity session as part of the programs. So schools do provide a nice campus for that.
Thank you. A lot of people are interested in barriers, facilitators. This one person is interested in data or building data partnerships with the private or nonprofit sectors to integrate more data information that is outside the medical government sector. And if so, what's working with those data partnerships? What are the challenges, any barriers that you've overcome?
Yeah, it's a great question. I think we're just at the beginning, as many of us are looking at the social drivers of health or social determinants of health, and really understanding how do we, best support the service agencies that have the data. So, as researchers, we're really interested to see, in a way, like our guidelines, being complied with. So, our children who have high BMIs being screened. Are they having laboratory follow-ups? And then are they getting referrals? But a lot of that is paired at that same time with social determinants, right? Is that same family being screened for food insecurity? And then are they being referred either to a federal assistance program like SNAP or WIC? Are they being referred to a food bank or food pantry? And so it really, for folks in the healthcare setting to take the time to do the screening for that social risk, it really benefits them to have information flowing so that they know that if they make that referral that the family has followed up and that the family, is getting those resources. Our family healthy weight programs are really built with low-income families because, we often talk about that we can't do training on nutrition facts panels if there's no food in the house, right? We really want to be ensuring that we're doing the nutrition education and behavioral support along with other assets. So really trying to ensure folks that are eligible who might be struggling with something like food security are getting those other benefits. And so that data flow is interesting to think about who's got which information, because it might be that the food pantry and the food bank collect information on folks that are coming in, but due to privacy, right, aren't able to share that information back. So really, working with communities to see what is the type of meaningful data that each of those partners need.
Thank you. There's a lot of excellent questions coming in. We're going to try to get to all of them. We only have about 4 minutes left, but let me ask you this question. This person's really interested in telehealth. So could you please discuss more about behavioral telehealth interventions that could be promising? Are these reimbursed by public, government, health insurance programs? Do you recommend using or she goes on to say, do you recommend using body composition measurements other than BMI to measure progress, for example, BIA? Two parts to that question.
Right. So I think I'm not an expert in the telehealth, but I definitely did see that a number of the programs that we were working on during the pandemic did offer some portion of their programming with telehealth. Some of that could have been Zoom cooking classes. It might have been some Zoom physical activity sessions, and in some parts of it, nutrition ed. So I think because of the waivers that were coming through because of the pandemic, I think some of those did receive, some level of reimbursement. But I'm not an expert in there. But definitely the waiver system allowed more telehealth. Body composition questions. So, some of the groups do use things like waist circumference. Most of the places we're working, like Park and Recreation or other kind of community settings, don't have fancy ways to really measure BMI. So a lot of the behavioral questionnaires are really helpful, right? We're looking at healthy foods, sleep, stress reduction, physical activity. So putting an emphasis on the behavioral modification and what that family's goals are. We don't emphasize the weight loss component of that with children. When they are taking part, they do have a baseline and then eventual other measurements, but really not relying on that. It's helpful for us in the study aspect, but it's really about getting kids to get moving and feel good about their choices.
All right, let's see if we can squeeze this last one in, and then we'll wrap it up. So I know you mentioned food insecurity as one social determinant of health. This person's interested more broadly. Is CDC interested in the concept of social determinants of health in connection with EHR as well as CODI?
Yeah, so our whole agency has a large equity initiative, and our center has a huge initiative around social determinants of health. Some of the data that CDC's been overlaying, it comes from some of the GIS systems. So the Social Vulnerability Index, or the SVI, is a way for folks to really be looking at kind of the social drivers as it relates to diseases like obesity, diabetes, cardiovascular disease, COVID. The Environmental Justice Index just came out last week out of the agency, which also may benefit because we often know that historically socially disadvantaged groups may be living in areas with high particulate matter, with other kind of toxic areas. So definitely, being able to show more complex data as it relates to risk. Because I think, we as a health agency really work with coalitions often, right? So food policy councils, equity task forces. It's really often the data may be at very different levels of what the coalition needs to really prioritize the work that they're going to do. And they are able to bring in things on their housing security issues around, bus transportation to healthy food retail. So different social partners have different data they can bring in. But CDC, we really work to provide technical assistance to the communities. Often they're never sending that information to us. It really is allowing the locals to really, local partners to really maximize their data.
Okay, I'm looking at the time and it looks like we're just about out of time. I know there was a few questions that we didn't get a chance to be addressed. So we'll check it back in with Heidi later, see if she might be able to help us answer those questions. We'll post the answers to our website. Just to wrap up, thank you again so much, Dr. Blanck, for for your presentation and answering all of these excellent questions from our audience, a very engaged audience today. So thank you so much. And I'd like to thank our audience again for attending. So recording of this webinar will be archived and shared on our website, noted on this slide at a later time. So please check in for that, for anything you might have missed. If you have questions about the Prevention in Focus webinar series or would like to receive a copy of today's slide, you can contact us as on the screen here, preventioninfocus@nih.gov. And last thing, just in closing, we have 2 very exciting webinars in the works for October. So please stay tuned for more information in your inboxes, hopefully, to register for those. So I hope everyone has a fabulous rest of their day. Thank you so much again, Dr. Blanck. That was a fantastic session. Have a great day, everyone.
Thank you.
Thank you.